Welcome, everybody. Today we're going to be talking to you about bariatric surgery and the process that is involved with getting to that type of surgery. My name is Angela Simmons. I'm a nurse practitioner here in the practice, and I run the program. I'll be talking with you after Dr. Zong speaks to you a little bit about the surgeries and some of the issues around surgery. So, Dr. Zong?
All right, so let me start with the indications for bariatric surgery. So there are two indications. One is if your body mass index is 35 or above, and you have weight-related medical problems, the most common ones being reflux, diabetes, high blood pressure, and sleep apnea. There are a bunch of other ones, but those are the most common. The second indication is if your body mass index is 40 or above and you don't have any medical problems. With these two indications, your insurance should pay for the surgery. There are three primary surgeries that we offer here. I'm going to start with the lowest to the highest weight loss. So the first one is the laparoscopic adjustable gastric banding. It's in your pamphlet if you want to find the picture. Oh wait, we don't have a picture for that, do we? That's the only one. Sorry, that's the only one we don't have a picture for.
But if you go on our website, there is information about each of the three surgeries Dr. Zong's talking about.
Okay, so for the gastric band, this is an outpatient procedure. We put a silicone band around the upper part of your stomach. We make a little tiny pouch with the upper part of your stomach. And this band is connected to an adjustable balloon that is then connected to a port that goes underneath your skin. So you get the surgery done the same day, you go home, and you come back and see us again, and we start doing adjustments to your band with the port that goes under your skin. Weight loss for this is around 50% excess weight loss. And when I say excess weight loss, that means that if you are 100 pounds overweight and I say 50% weight loss, then you lose 50 pounds of the 100 pounds that you're overweight. It's not 50% of your overall weight. The second surgery that we offer is the gastric sleeve. For this procedure, we take out about 75% of your stomach, and what you have left is a banana-shaped stomach that's around 90 to 120 cc's. So if you drink any alcohol, that's like 3 to 4 shots of alcohol. That size of a stomach. Weight loss for this procedure is around 75% excess weight. The next one that we offer is the Roux-en-Y gastric bypass. And that procedure, we make a small pouch with the upper part of your stomach. We completely separate it from the rest of your stomach, and then we reconnect the small pouch to a piece of small intestine further down. So the rest of your stomach is bypassed, and you just end up with that tiny stomach left. It's about 30 cc's in volume, so that's like 1 shot of alcohol. Excess weight loss with this procedure is around 80%. There are other procedures that we offer, but those are the three primary ones. If you had a previous primary bariatric procedure and you regain the weight for whatever reason, you think you want to get converted to a different procedure, we could do that. Or we could revise whatever procedure you had before. Do you guys have any questions? Yes?
I thought this surgery was irreversible. How can you revise it?
Okay, so if you had a gastric band placed and it's just not doing well for you, you have really bad reflux, I could just take that out. The sleeve, that one isn't really, well, if you don't lose enough weight with that, we can convert you from a sleeve to a bypass. We just take the top part of the sleeve and connect that to a small piece of intestine further down the line. Or if you, for whatever reason, you've been eating the wrong things and you stretched out your sleeve, we can re-sleeve it. and make it smaller.
What about the bypass being reversed?
The bypass is reversible because we're not taking out any part of your stomach. We can reconnect if you, for whatever reason, if you lose way too much weight than you want to, and you're underweight, then we can reconnect that pouch back with the rest of your stomach.
So
That is reversible, yes.
it's just that what is that called?
Roux-en-Y gastric bypass.
That is not reversible.
That is reversible.
That is reversible.
Yes.
The Roux-en-Y.
The sleeve is not reversible. I can't get you from a sleeve back to your original stomach size because I already take out the rest of the stomach.
And with the bypass, is there a surgery beyond that for weight loss? A lot of people ask that question. Or is that the sort of end-all, be-all?
There is another procedure called the duodenal switch that people rarely do in this country. There are a couple of surgeons that do them, but that is like a combination of a gastric sleeve and a bypass. So they make the sleeve and then they bypass the intestines further down. But you can't go from a bypass to a duodenal switch. You can go from a gastric sleeve to a duodenal switch because you sort of already did half of that procedure.
I have a question. What
Yes.
is the recovery time for the sleeve and the bypass? Because obviously the band is outpatient, so.
Right. So for the sleeve, you stay in the hospital for a day and you go home the next day. For the bypass, we usually keep you for 2 days.
At home recovery process, like as far as patients coming in and sharing their experience, like how is the recovery process at home, like pain-wise, going back to work, such? I know it varies, but ballpark average.
Most people take 2 weeks off just because they're sore from the surgery. You're not going to be able to eat as much afterwards, so you're going to feel tired. So some people take a little bit longer than 2 weeks. That's totally up to you. Yes?
You were asking about the bypass. I was going to ask about the sleeve recovery, like how that was, the gastric sleeve.
The sleeve and the bypass recovery time is about the same because they're both laparoscopic surgeries. The bypass you stay 1 day longer, but that's pretty much it.
So you only stay 1 day. Oh, so you only stay 2 days after the...
After the bypass, yes.
Oh, gotcha.
Any other questions for Dr. Zoll?
I'm a little confused about the two, the sleeve and the bypass.
Okay.
It didn't sink in. I'm older.
Okay. There are 2 pictures on here. Okay. So the one in the middle here, this is the this is the sleeve. You see this big portion of the stomach over here that's separated from the rest of the stomach? This part is completely taken out. I resect that and it's gone. So what you end up with left is that little sliver of a stomach.
It looks like a sleeve. That's where it gets the name.
Right.
Like a curvy sleeve.
Like a sleeve.
So with the bypass is this picture up here. So with the bypass, I separate the top of the stomach from the rest of the stomach. You see the dotted line?
Bypass.
Okay, so I reconnect that with a limb of small intestine. I pull it up from lower down. So the rest of your stomach, that's what we call the remnant, the gastric remnant, that really big portion of it, that's all bypassed. So when you eat, the food doesn't go there anymore, it goes straight down into the small intestine.
And that's the one that's reversible?
Yes.
The gastric bypass?
Yes.
You're not removing nothing, right?
Right, I'm not taking anything out.
Okay.
I'm just rerouting everything.
Sounds good.
It's anatomy altering, but things can be put back the way they were.
Right.
Whereas with the sleeve, majority of the stomach has been removed and it's out of your body.
Gotcha.
So what do most people have done? I know you're going to say different, but what is the best way to go?
The most popular one right now is the sleeve.
It's the sleeve.
That might change. I mean, things change every couple of years, so.
I like knowing that if anything goes wrong, it can be.
How about like getting sick afterwards? Like you hear horror stories of people getting gastric bypass or whatever, and they eat and they get really sick. I mean,
You mean the diarrhea afterwards? That's called the dumping syndrome.
okay.
You get that with the bypass because if you eat anything that has a lot of sugar in it, and it goes straight down into your small intestine. Your intestines aren't built to deal with that so fast, so when you get that, it just it sucks all the water in and makes you have diarrhea.
And with
Sort of
either-
an osmotic effect.
With either surgery, there can be some untoward side effects, some nausea, some dehydration. Much of it can be avoided with behavior. We talk about, and I'll discuss this a little bit further, how to eat afterwards. You're counseled a lot on behavioral modification. But sometimes there are, just symptoms after either surgery. Again, the most common are nausea, dehydration, occasionally vomiting, but most of that is on the immediately post-op side, not very often.
Long-term.
It can be long-term, depending on behavior and depending on the surgery itself. But, so that sort of goes with either territory. Do you agree with that, Dr.
Yes, I do. So your diet's going to be a little bit different depending on which procedure you choose. If you stick with the diet, then the side effects should be minimal.
And if you don't stick with the diet, there's a chance you can regain weight, correct?
Yes. You can stretch out your stomach. If you had a sleeve and you eat all the wrong things, your stomach can go back to its original size, like I didn't do your surgery. And with the bypass, if you eat too much, you just get diarrhea. You can stretch out your pouch too.
What is like a typical diet for a gastric bypass?
So you stay, it's very similar with the sleeve. You stay on a high protein, low fat, low carb diet. You eat multiple meals a day. And you have to sip water throughout the rest of the day.
So it's definitely high maintenance. It's, eating every 2 to 3 hours, and a portion would be maybe a cup of food, maybe a small salad plate, not a portion like you would get at a restaurant or, even a fast food place. So it's much more minimal, as to what you're eating for each of those 5 or 6 meals throughout the day. And again, that's one of the things that the dietitians focus on and sort of really, go over with you in great detail and try to prepare you for. So, any other questions for Dr. Zong?
Yes.
Does anybody here do, you said, there's another one out there that a few surgeons do?
The duodenal switch, nobody here does that. We usually reserve that for body mass index of 50 or higher, because that gives you the highest weight loss. It's about 90% excess weight loss.
Well, I think that might be it. Go ahead.
Okay, so having the bypass is going to cause you probably more problems with your diet, with eating, with things that can happen afterwards than the sleeve.
Yeah, you would have to be more careful with the bypass diet.
Because I've heard horror stories about somebody eating and then having to rush right to the bathroom, or
Right.
they say it either comes up or goes out. And that is...
Well, it usually doesn't come up because you can't really throw up with everything that's bypassed. Usually it goes out the other end.
Well, it's only 5% difference.
Right.
Well, and again, that is very much related to, can be very much related and controlled with diet. So if you're adherent to the recommendations, a lot of that can be avoided. So
Gee,
It just
depends.
depends on how much you feel like you want to be able to eat afterwards and what kind of diet changes you're willing to make. All of these procedures will help you lose the weight initially, but the rest is up to you in the end. So if you don't keep up with your diet and your exercise after your surgery, you'll still lose the weight, but then you'll regain all of it back and probably a little bit more than that.
No,
So compliance with the program is super important. Surgery is just one piece of it, or it's a tool for overall success. So, okay, I think
she had another
But
question.
did you say that the bypass and the sleeve diet was the same?
They're similar. They're not exactly the same.
They're not exactly the same.
Yeah.
Okay.
we can certainly, and for more questions about diet and everything, we'll certainly address those with you with the dietitians. right now I think we're going to move on to the piece about the insurance. And then, you will also, when you get to meet with the surgeon one-on-one, you can certainly dive into which surgery is better for me. You can discuss that individually based on your history and your personal information. The doctors can give you a recommendation as to which one may be more appropriate for you individually.
All right. Any more questions? All right. Well, let
Thank
me
you,
give this
Dr.
back to
Zong.
Angela.
Thank you very much.
Give that to you.
All right, no problem. Nice meeting you guys. Nice meeting you.
So at this point, we're going to talk a little bit about what's required for insurance to be a payer source for if we've given you these pamphlets here. All of this paperwork is available online as well. So if you need to go back at home and look over, if you happen to lose this, it's all online. I have really bad OCD, so it tends to be really very specific, and there might be a little bit more in here than you need to read or know, but it should be pretty thorough. The first page that has bariatric helpful hints just explains a little bit about co-pays and insurance end of things. The girls at the front office are very helpful, and they can give you some good information if you have insurance-related questions. Another page I did put in here, it talks about insurance coverage, and if you are somebody who likes to know how the answers were obtained, you can call the insurance company and find out for yourself basically what I'm going to be telling you today. It's the page that has the codes on it, and it basically tells you to get the number on the back of your insurance card and call that number, and it tells you some questions to ask. Number one, do I have bariatric coverage? Is that part of my benefits? Number two, what do I need to do? What criteria needs to be met for me to utilize those benefits? So these are questions that, again, I can help you with individually a little bit, but you can go ahead and call ahead to your insurance company and find out if you have coverage. Another way to do it is if you have a booklet of benefits, you can look in that booklet and it should tell you if it's a delineation of your coverage. The other backside of this one paper that says guidelines for the surgical patient, this just outlines what's in this packet, so I'm not going to spend any time on that page, okay? But the one question, if you are going to call your insurance company, this is not meant to be homework for you that you have to do. It's a recommendation. One thing I would ask is if you're going to call, find out if you need to have your surgery done at a particular center. Atlantic General is a center of excellence for bariatric surgery. We are covered through MBSA QIP. We are considered an accredited center of excellence. We are also a center of Blue Distinction with Blue Cross and Blue Shield. But there are certain other insurance companies that may say you need to have your surgery at an Aetna center of distinction. So it's good to know that ahead of time before you start the program here and expect that Dr. Zarif or Dr. Zong would be able to do your surgery, because the only place they have privileges is here at Atlantic General. If you're required to go to another facility, then we would want you to find that out ahead of time before you invest in, you could do your program work with us here, but if your heart is set on having one of our surgeons, you might be disappointed. So it's not very likely that that will be the case, but just to put that out there.
You said you guys have a relationship with Blue Cross and Blue Shield.
We do, yeah. And so most Blue Cross Blue Shield plans don't require a center of distinction as the place of surgery, but there are a couple different plans. We've seen it happen before, so that's why we went after that designation, and we just found out that we got it. So we're happy about that. The first page I'm going to spend a little bit of time on is, it says bariatric programs, pre-op expectations. So there are things that you would have to do to meet criteria before surgery, and things that you'll have to do after surgery. So before surgery, has anybody done any homework and understand or know what has to happen for you to? So basically, the insurance companies want to see that you've had some dietary counseling. They want to see that you've invested and had some education on good nutrition. Here in this practice, in this program, we use dietitians, registered dietitians. We have 2 of them, and they're both wonderful. And what they counsel you on is how to eat. How many calories do you need? How much protein is sufficient? differences between men's and women's diet. There's a variety of different things. How to chew. Did you know that there's a special way that you need to chew after surgery? To use a straw or to not use a straw. So there are very specific things that these ladies put into their notes when they see you and counsel you. And so it's very important that you pay attention and learn and utilize the skills that they're going to be teaching you, because after surgery they're critical to survival, if you will, and to maintaining your success from surgery. So the dietary counseling is the biggest piece of a program, okay? In the realm of insurance, there's Medicare, and then there's sort of everybody else. Medicare requires kind of an abbreviated program. The minimal program it's 3 months that they require. Everybody else, meaning Aetna, Blue Cross Blue Shield, Coventry, United Healthcare Priority Partners, and that's not an exhaustive list, requires at least 6 months of a program. Okay, so they want 6 consecutive months of dietary counseling. So I'm going to come back to that in just a few minutes and explain how we arrange those nutritional visits for everybody. The next piece is a psychiatric evaluation. You'll need to have some kind of a documented visit with a mental health professional. And this is to document that you understand the gravity of the surgery, that it will be life-changing, that you're doing it of your own volition and not because somebody else asked you to do it or told you need to have this kind of surgery. It's to make sure that you don't have history of an eating disorder or some other kind of history that might be, the surgery might be contraindicated for and might make it, be riskier for you. So it's a one-time kind of cursory visit, and that health professional would kind of vouch for you and say, yes, I think this is a good candidate for surgery, or maybe some counseling would be necessary prior to surgery, or maybe this wouldn't be a good fit for this patient. So that's required. And that's pretty much across the board for anybody. Yes, ma'am?
Is that just the form you need them to fill out, or do you want them to put something in words?
So that's a great question. The question is it a form that you have to fill out, or do they put it in their own words? I do give, and in this packet there's a few bullet points of what insurance companies are looking for. For instance, do you have any history of physical or mental abuse? Do you have any history of substance abuse? Have you had history of an eating disorder? So there are some suggestions of things to include in the note for some provider who may not know what exactly to include. And others have a set go-to list of things that they know that they would include in the note. So it's kind of up to that individual provider. Again, in this packet, there's a page that talks about psychiatric considerations, and there is a list of local providers that you can choose from when you call to set up this appointment. Okay, so, and if you have a counselor that you see, or a social worker, or a psychiatrist or psychologist, you can use that professional if he or she is willing to write that note for you. That's fine if you have rapport with somebody, but if you don't, there's a list here of providers to choose from.
But what about the on-campus dietitian who I've been meeting with?
Okay, great question.
Is that something that I could use now?
Yes, sir. So if you've seen and worked with a dietitian in the past and you want to use those notes, they do count. It does matter if you've done some work. What we would require is that you would see our dietitians at least 2 times. And the reason is we want to make sure that you've gotten the critical information that's relevant, particularly to bariatric surgery, because the dietitian you may have been working with may not have included some of those things. They may not have tailored it to bariatric surgery. So, and we can talk at your initial appointment and see what you've done. And so if anybody's done work already, they can get the notes here for us and we can review. Again, the key is for most insurances, they want to see consecutive visits. So if you had a visit sporadically here, in June, and then you had one in September, it may not be enough. So they have to sort of be consecutive, but we'll get the notes. The next piece is weight loss prior to surgery. During the course of your program, the insurance companies want to see that you're making some progress. In other words, that if you're putting effort into better nutrition and activity, that you're able to lose some weight. Now, Angela, I wouldn't be here if I could lose weight on my own. We understand that. We understand that this is difficult. But what the insurance companies want to see and what we want to see is that you're able to demonstrate compliance with a nutrition program and possibly some exercise, okay? So what we ask is that you document and journal. You know, I'm trying to eat 4 to 5 times a day. I'm trying to keep my calorie count to such and such. I'm trying to include this many grams of protein. I'm trying to stop drinking soda, okay? There's a misconception that everybody that's overweight eats all the time, and that's not true, is it? Right? Lots of times people skip meals. They don't eat but once or twice a day. So we want to see that you are eating 4 to 5 to 6 times a day. Again, small meals, okay? Coupling protein with fruits and vegetables. So the point is, the key message here is document. Journal, journal, journal. I can then take those journals and I can submit them to the insurance company and say, this person may not have lost 5% of their excess weight, but she stopped drinking soda. He's exercising 5 days a week for 20 minutes and working on maintaining a 1,200 calorie diet. You see what I'm saying? So it gives you some validity and credibility as to that, to attest that you're doing what you should be doing.
Question.
Yeah.
What, excuse me, what would be the alternative to like a traditional exercise regimen? Like, for example, I had knee surgery a few years ago to fix my MCL. I can't get on a treadmill. I can't ride a bike, those kinds of things.
We hear this often. People with limited mobility say, how can I exercise? I have knee problems, I have back problems. And when I hear somebody say I can't, I just ask, what can you? Okay, so there is always a modification. There's always a way to get somebody to move. Even if it's sitting in a chair doing arm and leg exercises, we just ask that you try to do something. And we can work with you to get you into physical therapy. Maybe the pool is an option. We can, again, give a prescription for that, for physical therapy. So if access to a pool is difficult, there are ways around and there are suggestions, and we can talk with every person individually as to what might be a good option for you if you have limited mobility and are unable to partake in a routine or regular exercise regimen. So nope, everybody doesn't have to go to the gym. I don't need everybody to have an expensive gym membership. I just ask that maybe you try to go up and down the stairs in your house, walk to the driveway a couple times a day, sit on the floor and try to do a couple sit-ups, or what can you do? So if you can't, let's turn it around and say, what can I? So does that help? Mm-hmm. Okay. Anything else that's required here would be at the discretion of the surgeon. So if the surgeon says, well, sir, you had history of lung problems, I want you to see a lung doctor. Or, ma'am, you had history of a heart attack, I want you to get clearance from your cardiologist. That would be at the discretion of the surgeon and based on your particular medical history. The other thing that we require that insurance does not require is support group attendance. We ask that you come to 3 support groups over the course of your program. Those support groups are held here in this room, and they're about an hour long apiece. And the content is usually either nutrition or behaviorally driven. The dietitians usually will run the nutrition groups, and sometimes I'll do a class about, stress management or overeating, or there are different. The classes are different. Lots of times we'll have a testimony from a patient who's already had surgery come in and talk, and that's really nice because that person can kind of give you a perspective that we can't. I haven't had the surgery, so I can't speak to what it's like to go through the pre-op or post-op diet or experience nausea afterwards or whatever. So patients usually seem to enjoy that it's time to talk with peers and people who are going through similar struggles, and usually we're kicking people out the door at 7:30 at night when it's when we have those groups. So I'm going to show you in here a schedule of those classes in just a moment. The page on the back here talks about post-op expectations. What we require after surgery is that you come to your post-op appointments. Okay? We want to see you. We want to find out, are you having problems? If you're having problems, what can we do to help you? We want to see, are you losing weight? Are you not losing weight? Why do we think that's the case? It says post-op expectations. If you don't have one, we'll make sure you get one. So we want to take care of you, and we don't want you just to say thanks for the surgery, see ya. Okay. I always like to tell people too, this is how we get our data. This is how we collect our numbers. So this is how we can tell how successful we are. And if you were going to see an orthopedic surgeon to have your shoulder worked on, wouldn't you want to know his or her success rates and infection rates and blah, 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 statistics, right? So I can't, collect statistics if I don't have people coming in after surgery to tell us how they're doing and to be able to weigh them. I can tell you, I see every patient post-operatively. We have very, very good results. We have, knock on wood, we have low complication rates, and we have high success of people losing weight after surgery. On average, a person will lose 10 to 20% of his or her excess weight. So for that 100 pounds being overweight, 10 to 20 pounds of that in the first couple weeks after surgery. Again, on average, for that first year after surgery, our patients are losing minimally 50 to 60% of that excess weight, and sometimes up to 80 to 90% of their excess weight. So people are doing well, okay? The people that do the best come the most. They come to, and they're compliant, meaning they're adhering to their diet and their routine and their program. Yes?
I have a question. Post-op, do you also offer the skin removal portion of this? Patients who are,
So skin removal after surgery is a big deal. That is very individual as to if it's done. Dr. Zarif has done what we call paniculectomy, removal of excess abdominal skin before. It gets a little hairy because it's not covered by insurance. So unless there's another health issue such as a hernia, it may be difficult to become covered, and most insurance companies want patients to wait up to 18 months after surgery for maximum weight loss, results. In other words, they don't want you to have it done after 6 months and then maybe you regain some weight, and that you see where I'm going with that.
But that is an option. If you wait the 18 months, you're compliant.
It may be an option. It would be something that you'd have to discuss with the doctor individually. Other areas such as arms and legs are more in the realm of cosmetic surgery and plastic surgery. So we can refer you to somebody, okay? I want to move on to the nutrition assessment form. The paper in here, this is an assessment that we ask everybody to fill out and bring for your first visit with a dietitian. This is very important to find out what are your isms. In other words, do you skip breakfast? Do you drink soda? How much? Do you only eat one meal a day, et cetera, et cetera? There's no judgment in this. We just need to know so that we can give you good, valid feedback and comments as to, hey, you're a great vegetable eater. We want you to keep that up, but maybe couple it with a protein. Okay, so it's just to give you good feedback. There is at the end of that assessment a place for you to journal. You can do it here on pen and paper. You can do it on your phone, your home computer. MyFitnessPal is a great app. I don't have stock in that app. I'm just saying it as an example. Lose It is another great app you can use. They're free, so you can use one of those, or you can do good old-fashioned pen and paper. What we ask is just to try to count calories. Try to give us some exact numbers. Okay, I ate a cup of cooked pasta. I ate 4 ounces of a chicken breast. I ate or drank X, Y, or Z. Okay, so give us some ideas, because that will help the dietitians be able to give you good, valid feedback. The next thing is the group calendar. We have right now actively involved in our program 180 plus patients. We have 2 part-time dietitians. So we're working on maximizing our utilization of those dietitians, and we're working on maximizing how many people we can see a month. The way we do that is we have group visits. So each person has to do 3 or 6 months of dietary counseling. The way we're accommodating everybody is we're having group visits. Okay, so there are 6 group visits a month. A couple of those are pre-op visits, meaning they're reserved for people who are at the end of their program and they're doing their last visit, and the girls give their pre-op education together. At the very minimum, each one of you will see the dietitian one-on-one at least one time. Okay, just you and the dietitian to go over your personal, specific plan. The majority of the rest of those visits will be in the group setting. Those visits are here in this room. Okay. When you leave today and you say, Angela, I'm ready to join the program, I really want to get involved, I'm ready to do this, what you'll do is you'll talk with the girls. They'll get you a surgeon appointment. The first visit is with the surgeon to establish relationship, to make sure that you're a candidate, and then to order basic baseline testing, lab work, an upper GI, test that takes pictures of your GI tract and make sure that there's no hernias or refluxing. The blood work is usually just a chemistry panel to look at your kidney and liver function, blood work to make sure, are you anemic, are there any other blood related problems, thyroid function, lipids or cholesterol, to test for diabetes, so etc. So that first visit's with the surgeon. The next visit, at that surgeon visit, when you come, you'll be scheduled for your dietitian visits. And so the girls will ask you to choose some of the visits that you would fit your schedule best. You do get to try to pick which ones that would be most convenient for you, and then they'll try to lay out the next 3 or 6 months of visits for you, okay? We try to keep every Medicare patient 1-to-1, but sometimes you might have to attend a group visit. So it just depends on what we can get you in, and accomplish first. Okay, so we'll try to be efficient with the scheduling and try to get you in as soon as possible. On the back of that sheet, or maybe the next sheet, is a schedule of the support groups. Remember, those are the group visits that are not required by insurance, but we still want you to do them. Those are visits that last about an hour, and you only need to do 3 of those. You can just pick 2, and you come whenever you want. If you want to do all 3 of them back to back, you can do the first 3. If you want to do one at the beginning of your program, the middle, and the end, you can do that. Or if you want to save them all till the end, I don't recommend that, you can do that, okay? They're held every 2nd and 4th Wednesday of the month at 5:30 p.m., okay? And again, people do enjoy those. We try to change it up. The next thing in here is a checklist. Because there's so much that you have to do for this program, I try to put it all in one place to let you know and keep you guided as to what things you've already done and what things are left to do. Again, you have to do blood work, you have to do an upper GI, you have to have so many dietitian visits, the support groups, etc., the psych visits. So we try to give you an idea of when to get those things done, and we ask that you bring this with you each time so that we can sign you off and let you see your progress and let you, keep a conscious tally of what things you might need to still get done. Lastly, I've included some papers in here, just some basic information, some frequently asked questions about the sleeve as well as the bypass. When it comes time to decide which one is right for me, that's something that you'll sit down and discuss with the surgeon. Again, Dr. Zong alluded to that the decision may or may not be based on your body mass index, how overweight you are. It may or may not be based on what you have heard about and what you've learned from a friend, a loved one that's had the surgery. Your personal preference. I just think I like the sleeve better or the bypass better. So this is something that you'll discuss with the doctor individually, okay? But just in general, they're both done, at least attempted laparoscopically. Again, knock on wood, I've not seen anybody be opened for the surgery. They're attempted laparoscopically. You're held overnight for the sleeve and up to 2 days for the bypass. Pre and post-op diet are pretty much the same. And again, that's something that you discuss with the dietitians. The recovery time, because it's laparoscopic, is usually pretty quick. We see you back here at 1 week. We do follow-up phone calls at 2 days post-op to make sure that you're not having any problems. We try to keep you out of the ER, and we try to keep you happy and reassured and safe. So you can always call after surgery. I tell people, email me, if you're having a problem, even if it's after hours. People know how to get a hold of us is the problem. And so usually we can stave off a problem before it becomes a problem. Hey, I'm feeling like I can't drink. Okay, come on over and we'll give you an infusion of fluids. So we like to know what our patients are experiencing and how they're experiencing it, and that way we can avoid lots of post-op complications. Last but not least, there is a reference link here to the bariatric, National Bariatric link. This is a great place to go. It's a good resource, just individual questions about the surgeries in general. And there's some different things that they cover here at this site. One little thing I'd like to mention, it's a weird thing to mention, for the ladies out there of childbearing age, we do recommend that you consider an alternate plan for family planning and try to avoid pregnancy for a year and a half-ish after surgery. There are two reasons for that. The first and most important reason is if you've had bariatric surgery, you may not be able to nourish a viable pregnancy. Your stomach is very much, it's a lot smaller. So you may not be able to eat to nourish a pregnancy. And the other obvious reason is, the idea is that you're going to lose weight after surgery, and pregnancy is the opposite of that. You need to gain weight. So we remind people just to have that in your forethought. If you're trying to have bariatric surgery at the same time that you're trying to start a family, maybe you need to revisit one or the other of those priorities. So having said all that, and you've listened to me talk now for a while, is there any question that I haven't covered or anything that's a burning concern for you? Cricket? It's a lot. But what I would suggest is go over the paperwork. There are videos online of each of the different surgeries, how they're done. If you go onto Atlantic General's website, www.atlanticgeneral.org, and you go under our services, you'll see bariatrics, and then you can go and look at, again, the different paperwork. There's forms there, all these forms. There is information about each individual surgery. Our team members are there. In our pamphlet here, there are pictures of the dietitians and the surgeons. If you have a surgeon preference, you can certainly let the girls know, and they'll try to accommodate that. They will accommodate that. Just know that if you do, you may have to wait a little bit longer if that's an issue for you. Otherwise, you can ask to speak or ask to get into the first available surgeon. I'll tell you, I've worked with Dr. Zarif now for many years, and I would go under his knife any day. And from what I know of Dr. Zong, it's I've worked with her a lot less time, but I think she's a wonderful surgeon, and I really her patients have done extremely well from what I've seen. So again, I would go under her knife as well.
How long has she been here?
Dr. Zong has been here for about a year, but she was not a new surgeon before that. She practiced in New York before coming here. So
There's a support group tomorrow night. Are we eligible to attend that?
Sure, you can come check it out.
Does that count as one of our?
It can, absolutely. We'll give you credit. Sure. So just make sure you sign in. And right now, I would say, after this meeting, before you head up to the front, let me sign off and on your checklist that you came to the support group, and that's one last thing you got to do. And then I'll also sign off on the paper that says pre and post-op expectations. We'll sign that, and that will go in your chart, just saying that you've heard this spiel, you understand what the expectations are, and you're on board.